Good morning, everyone. Thanks so much for joining us. We'll just give it, I think, one more minute to let people get logged on, and then we will get started.
How'd you freeze again, Christy?
Ugh.
Good morning, everybody. Welcome. Christy's having some freezing issues with technology. Oh, there she goes.
Yeah, it says my internet connection is unstable, of course.
Of course, yeah. You froze a little bit, but I was letting folks know that you're having a little in and out issues.
Thanks, Chelsea. Can you hear me okay?
Yeah.
Okay, maybe I'll just keep my video off. I am joining you today from Minneapolis, Minnesota. So if I had my video on, I would show you the fabulous wallpaper from the 1970s that is in my father's den. All right, it looks like we have a great turnout today. I'm gonna get us kicked off. Chelsea, if you could just let me know if I ever cut out or something.
Yes, I'll let you know.
For being my wing woman here. Okay. Well, good morning, everyone. My name is Christy Hudson, and I am the Cross-Sector and Strategic Initiatives Coordinator for Oregon Health Authority's Public Health Division. Welcome to our second Healthier Together Oregon in Action event. We're thrilled that so many of you are joining us today. We have launched a series of these events to help folks across the state of Oregon dig a little bit deeper into the strategies and activities of Healthier Together Oregon, our state health improvement plan. Before we begin, just a few housekeeping items. We have quite a number of people registered for today's event, so please ensure your lines are
lost
muted.
You, Christy.
Oh, shoot.
There we go.
Please ensure your lines are muted for the duration of the event. We invite you to introduce yourselves in the chat. Please share your name, your pronouns, and what brought you to HTO in Action today. We love an active chat. So throughout the hour and a half, please share information and thoughts, reactions, resources, make a friend, ask questions. We really love to see engagement in the chat. Encourage you to use that. Closed captioning is available. I think Liz or Heather will be putting some links into the chat if you are looking for closed captioning. Welcome you to have your cameras on or off. We love to see faces. But if you need a little Zoom break, that is okay too. We will be recording this meeting for sharing, and we'll certainly share the slides and recording with those who registered for this event. And with that, Chelsea, can you see my screen? Is it just blank?
It is now blank, yes. Huh. It was the PowerPoint.
Yeah, interesting. Okay, shoot. I'm wondering if we're going to have some problems here.
I can share the version I have, but it might not be the final one you put together for today.
Yeah, I think it is. Do you want to do that, Chelsea, as we get through the acknowledgements? Okay.
Yeah. Thanks,
everybody, for your patience here. Thanks for introducing yourselves. Great to see you all.
All right, let me see if this works. I'll move my little chat. Did that work?
Yeah.
You see it?
Yeah.
Yay!
Great. Thank you. All right, do you want to advance to the next slide? I think we got the closed captioning links there. That's great. And Heather or Liz will be putting those into the chat as well. You can go on to the next slide. Before we begin, we just want to acknowledge important communities, starting with those who identify as American Indian or Alaskan Native in Oregon. We acknowledge that what we now call Oregon is the ancestral lands of many tribes, those now federally recognized and not. We are here because this land was and is occupied. and its traditional people were displaced by colonists and settlers. As settlers and or guests, we recognize the strong and diverse Native communities in our region today, from tribes both local and distant, and offer respect and gratitude for their stewardship of these lands throughout the generations. There's a link there. I encourage you all to take a look at that link and become more familiar with the Native communities in whatever part of the state you are joining us from. Next slide, please, Chelsea. OHA acknowledges there are institutional, systemic, and structural barriers that perpetuate inequity and have silenced the voices of communities over time. OHA is committed to partnerships, co-creation, and co-ownership of solutions with communities disproportionately affected by health issues, so they can actively participate in planning, implementing, and evaluating efforts to address health issues. OHA recognizes community-engaged health improvement is a long-term and dynamic process. OHA is striving to engage with communities through deliberate, structured, emerging, and best practice processes. OHA is striving to make engagement with public health effective for communities, especially those who have been, those communities that experience institutional, systemic, and structural barriers. So thank you again for being here to share with us and with each other how we can advance health equity for communities in our state. We are trying to do our work differently here at Oregon Health Authority, and we thank you for your graciousness and patience as we learn from and with you all. As I mentioned today, this is a second in a series of 8 events that we're putting on over the next year to highlight the strategies and activities identified for implementation of Healthier Together Oregon, our 2020 through 2024 State Health Improvement Plan. The purpose of these events is really to convene partners like you from around the state, folks who are working to advance health equity for priority populations. This is an opportunity to dig a bit deeper into the strategies and activities of this plan, to share examples of work in progress, and to connect with others. We have a very full and exciting plan for the next hour and a half, and I do hope that we'll have some time at the end of this hour and a half to connect with each other. In terms of the agenda for today, we'll first provide a brief overview of HTO and the strategies within the behavioral health implementation area. And then we're going to turn it over to partners who are doing this work. Really excited to be joined today by folks from the Yellowhawk Tribal Health Center, Oregon Pediatric Society, and Citizens for Safe Schools. We had hoped to have someone from Holistic Healing Behavioral Healthcare with us today. They unfortunately were not able to attend, but we will share a little bit of their work in a video that I think will be really moving for all of you. And then finally, if we have time, we'll make some time for breakouts. But again, really encourage you to share and dialogue and connect with each other in the chat. All right, and one quick polling question just to give us a sense of where you are all coming from. Please let us know where in the state you are located. Coming from Portland Metro, Willamette Valley, the coast, Southern Oregon, Central Oregon, Eastern Oregon. Oh, and for some reason it's polling second question too, which will be great. I was hoping that would be at the very end, but let's do it now and we can see see how things change. Okay, I'll give you 10 more seconds. And all right, Chelsea, are you able to see that? Where people are coming from? Yeah? I can't hear you. You're on mute.
Yes, we're able to see it.
Okay. Thank you, Tori. All right, about half of you coming from Portland Metro, handful from the Willamette Valley and the coast, Southern Oregon, Central Oregon, Eastern Oregon. Folks from all over the state, thank you so much. All right. So briefly, I'm going to try to breeze through this just for those who may be less familiar with this plan. Healthier Together Oregon is our state health improvement plan. Most states have a plan. This is the plan for Oregon. It's a strategic plan that identifies our health priorities with strategies to advance progress in those priority areas, and specifically to advance health equity. 5 priorities were identified back in 2018 by a steering committee. So the priorities of this plan are institutional bias, adversity, trauma, and toxic stress, economic drivers of health, access to equitable preventative health care, and behavioral health, which is the focus of today's event. There were 62 strategies that were identified by subcommittees that convened around each of those 5 priority areas, and they were the ones that really developed the meat of this plan. And we organized those strategies within 8 implementation areas, and I'll talk a little bit more about that. There are a series of measures, both long-term and short-term measures for this plan. Not going to go into a lot of detail about that, but do encourage you to visit healthiertogetheroregon.org, which is the website. Lots more information about the plan as well as the measures. And Chelsea, if you can go on to the next slide for me. All right, so the implementation areas, this is really how we've organized the work of the plan. And just briefly to kind of go over the types of things that are identified for improvement. Equity and justice, these are strategies that really speak to the role that state agencies have and other institutions have in advancing equity, particularly for priority populations, Black, Indigenous, people of color, and tribal communities, people who identify as LGBTQ+, people with low income, people with disabilities, and people who live in rural areas. Healthy communities, these are strategies that speak to how we can improve the built environment, how we can provide financial stability and economic wellness, as well as community resilience. Housing and food, pretty self-explanatory, how we can create affordable housing and address food security among families. Behavioral health, that'll be the focus of today. Healthy families, these are strategies intended to improve the supports that we have for caregivers in our communities, as well as access to preventative healthcare services. Healthy youth, these are strategies that speak to primarily how we can improve supports for school settings. Workforce development, these are strategies intended to increase a culturally and linguistically responsive workforce, particularly in health and social services. And then finally, technology and health. These are strategies related to use of electronic health records, telehealth, and community information exchange. So we'll be taking each of these implementation areas one at a time, and the focus of today is on behavioral health. And next slide. Oh, here. Maybe I can try and share my screen now, Chelsea, because I had a different slide here. Oh, it's still not working.
Oh, no.
That's so bizarre.
That's bizarre. Oh, technology.
Let me try one more time. I don't have it. Well, let me introduce Tori Algie. Sorry, Tori. I don't know, Tori, if you have that one pager handy, you could pull up while I introduce you in the role of the Alcohol, Drug, and Policy Commission.
Sure, I can pull it up. Yeah.
So as I'm sure you all know, right, when we talk about behavioral health, we typically talk about all things related to mental health and substance use. For the purpose of Healthier Together Oregon, we made some decisions pretty early on to work really closely and collaboratively with the Alcohol and Drug Policy Commission. Alcohol Drug Policy Commission is governor appointed and charged with developing a strategic plan specific to alcohol and substance use for the state of Oregon. And although behavioral health obviously includes all of that work, we didn't want to be duplicative or redundant with anything that the AdPC was putting together. So we made a choice to keep the behavioral health part of HTO pretty clearly in the mental health lane and let AdPC take the lead on anything related to alcohol and drug use. So what that meant is we had cross coordination and participation on subcommittees, and certainly a lot of the things that we'll be talking about today do tie to alcohol and substance use. And with that, I'm going to turn it over to Tori Algie, Senior Policy Analyst with the AdPC, to share a little bit more about the AdPC's work.
Awesome. Good morning, everybody. I'm excited that you all are here. I'm looking forward to learning about what you all do and you, your personal selves too, as we learn together this morning. So the Oregon's Alcohol and Drug Policy Commission also has a statewide strategic plan. It's a 5-year plan and very similar to the Healthier Together Oregon strategic plan. We too have 4 priority areas. The strategic plan is very big, a big document. It's like 90 pages, and so can be sometimes overwhelming. But in essence, it's broken down into these 4 priority areas. The first being system coordination and development, prevention strategies, rapid access to treatment, and finally, recovery support. And so, just as Christy mentioned earlier, we were very intentional when developing these 2 strategic plans in ensuring that we didn't leave gaps for people to fall through because our focus was so specific. But we also didn't want to recreate the wheel and having to dilute our resources because they're working on similar things within each of the 2 plans. And so we were both very, very involved from beginning to end with the development of both of these strategic plans. And that's something I'm very proud about, that we have broken down the silos that sometimes negatively impact Oregonians who truly need our help. I won't go too much into the weeds, but I wanted to give you guys some examples of each pillar. So when we speak of system coordination and development, we want to increase coordination amongst the different programs. Again, we want them talking to each other. We better understand what they're working on. So again, we're not duplicating efforts and or sometimes working in opposition. And so to ensure that, we have to meet regularly and talk about what we're doing, what our successes are, what are our lessons learned, so that others can incorporate positive programs that are working for others and maybe not embark on ideas that weren't as helpful. We're also within that gaze of community coordination and development. We want to do better with our data collection and then data analysis. Again, we want to be more innovative, not as reactive, but start to see trends earlier so that we can get in front of them. As it relates to prevention strategies, they are just that. We're looking at things that will help prevent people from incurring a substance use disorder. Some of those examples are retail and social access, decreasing those things, decreasing overservice at bars, things of that nature. Having interventions that include the entire family. So we're looking at the person and the community in our prevention strategies. Rapid access to treatment is just that. When people are ready for treatment, we want them to not have to wait an excessive amount of time. We want a system that is, again, on the cutting edge. We know what beds are available, where they're available, the populations that each program specializes in, so that when we're referring people to treatment, they get treatment quickly, but they also get the extra community supports that they need. For instance, if they need linguistic supports, we want to not just refer them to an open bed, we want to refer them to a program that has counselors who speak their language. And then finally, recovery support. We know recovery is a lifelong journey, and we want to make sure that people have what they need to be successful throughout recovery. There is one other, if technology will allow me to show you. Okay, really quickly, because I know we have a lot of presenters and they here we go. Okay, so this, I'm not going to go through this whole thing, but I just want to show you guys again how intentional we were in seeing where our overlaps were, our similarities, so that we knew, we weren't guessing, we knew who's on what base. So who has this portion of the strategic plan, again, to make sure there's no gaps. So there's many opportunities where the Healthier Together Oregon, or what used to be called SHIP, what they're doing is very similar to what we're doing, but with a different focus on the different populations. And so this is just a representation of all the awesome strategies that we've identified that we are both doing, but again, with different populations in mind, so that no one is left behind. All right. And I can send this out if people are interested in digging in deeper. Thank you, Christy, for an opportunity. I wish it was more, I could ask questions, but it's not time yet. But if you guys have questions later, feel free to put them in the chat or at the breakout session. I'd love to answer your questions.
Great. Thank you, Tori. Yeah, and please do share me that crosswalk so we can send that out with the materials. I know there was one question in the chat about how the AdPC interacts with Measure 110. So maybe if you can answer that question in the chat.
Okay.
And we'll keep moving.
Sure.
Okay. All right, now we're going to turn it over to Chelsea Holcomb with Oregon Health Authority Health System Division, who's going to provide a brief overview of the strategies within the behavioral health implementation area.
Thank you. I'm going to try to share again. Did that work? A thumbs up from anyone?
Yep.
Awesome. All right. So I'm going to go through, so I'll introduce myself, Chelsea Holcomb, she, her pronouns, and my role at the Oregon Health Authority is I oversee and direct the child and family behavioral health work. And so you'll probably notice some of the example activities I give may be focused on children and families, but they're certainly the examples I'm giving are not comprehensive to all things that Oregon Health Authority are doing or our lovely contractors are doing. So I just wanted to put that disclaimer that you may hear more about child and family behavioral health than adult behavioral health, because I wanted to stay in my scope and accurately represent what I know. But certainly throughout my presentation, if you have questions or you have examples yourself of any of these strategies from your organization or the work that you do, we really encourage you to put that into the chat. And if you have questions, or if I mention a website or a link that you would like access to, or in our follow-up materials, please put that in the chat as well to make sure that we give information. So I'm going to go through, I think it's like 10 slides of the strategies and activities under behavioral health for the Healthier Together Oregon plan. We're going to start with this one, which is enable community-based organizations to provide culturally and linguistically responsive information about behavioral health to people they serve. And some of the examples of the strategies, I think Christy mentioned at the beginning that the group came up with a lot of strategies. So obviously this is pared down for this presentation. So again, there's a lot of deeper information on the website and other materials. But we talked, some of the example activities are disseminating information about the behavioral health provider directory. So this is work that the Oregon Health Authority is doing to centralize and create kind of an air traffic control through Lines for Life and the work through 988. So 988 is similar to 911, is that it's becoming a centralized number to access behavioral health supports. And this is a national movement that's happening across the country. In preparation for that and in response to COVID, we've been working with Lines for Life to develop a behavioral health provider directory so that we can have a centralized access system. there was COVID investment grants that went to community-based organizations during COVID to increase access to information about behavioral health support and resources during the COVID. I keep hearing people talk about it as if it's over, but still during our COVID pandemic, getting increased access and with a target of those grants going to community-based organizations that were serving or run by communities of color. A focus on health equity and new behavioral health investments towards a vision of transformation. And so part of this strategy and activity will help focus the behavioral health investments from the recent legislative session in order to support communities. And again, getting that information out to people to reduce stigma and get the information they need in the way they need it to get what they need. We had an increased investment in Trauma-Informed Oregon to provide training and technical assistance to community-based organizations to be able to incorporate health and racial equity along with the trauma-informed strategies. And I saw Mandy Davis here. Yay, shout out to Trauma-Informed Oregon. And so their website is super informative. And I know they've been doing a lot of work during COVID as well. Another strategy is implement public awareness campaigns to reduce the stigma of seeking behavioral health services. And I think more is coming from Oregon Health Authority. I couldn't find any teaser information, but I think Here For You Oregon is going to have more information coming. But this is the idea. This is creating these broad-based marketing campaigns to again reduce stigma, target culturally specific populations. Rural audiences, because that looks very different than our urban friends and our I-5 corridor. And then really looking at the social media component. And here it talks about youth, but really a lot of people are on social media and different social media platforms. And that is a lot of way that people are consuming media and consuming news and consuming supportive strategies. So really looking at social media closely. During COVID, Oregon Health Authority invested in the Safe and Strong campaign, and there was a lot of work with youth and young adults to create messaging, images, and locations for those campaigns, and really using folks to help direct that work. I included the website here, but there's been, in addition to that, it was a helpline and website. And I think there's going to be, again, more to come and evolution of that work as we move through the COVID pandemic. Again, a lot of these campaigns are targeted of work. And I put a link there to the policy vision paper if people have more or want more information and to read that and get engaged in some of our events we're doing. Another strategy is create state agency partnerships in education, criminal justice, housing, social services, public health, and healthcare to improve behavioral health outcomes among BIPOC and IAAN communities. And there was a lot of strategies. I honed them down, but again, I would love to hear what folks are doing in this arena as well in the chat. Oops, and accidentally slipped the slide. But wanted to talk just a little quickly about the System of Care Advisory Council and the local systems of care. So this is a children's initiative that Oregon's been invested in for many years. And the goal of that is to really build a coordinated continuum of care for children and families so that they get what they need when they need it and for the duration they need it. And this new statewide advisory council was formed in 2019 through Senate Bill 1 and has been gearing up and pulling together a plan that they will be putting together in September for the legislature and the governor's office, similar to Healthier Together Oregon, the ADCP plan and behavioral health, but really pulling it together for the whole children's system. And that will be an ongoing plan that work group is working on with state agencies and community partners. In all of your local areas, there are local systems of care that have governance structures to help reduce barriers and work and bring agency partnerships together, again, to support children and families and young adults in behavioral health. One of the other strategy or example activities is convening formal partnerships that include state agencies identified in strategy. And so obviously you're participating in that now, and we're seeing that across the state. And there really is a commitment in behavioral health to really pull these plans together so that we reduce fragmentation across the state and we work together towards these goals. Another example I wanted to give is that there's recently a memorandum of understanding between the Oregon Department of Education and the Oregon Health Authority to really work together to focus on children's health and figure out how we can use both state agency organizations, initiatives, and investments to do that and do it well, and again, in a coordinated way, so that we're going in the same direction. Another strategy, improve integration between behavioral health and other types of care. And we're going to hear about some of that today. Oregon was part of demonstration projects from the federal government of certified community behavioral health clinics, affectionately known as CCBHCs. And this legislative session, there was another $25 million investment in this model for Oregon. And so that will be something to keep an eye on. And that is lifespan, that is not just children. But again, a different payment structure for our local communities to be able to serve children and families and adults in a different way. Other examples of looking at improving the system of communication and warm handoffs. And currently we did get an investment, again, this legislative session, to develop 24/7 mobile response and stabilization for children and families. And I could go on for a whole hour about that, but really changing the front door to the children's system and going upstream so that it is a family-defined emergency or concern that families are able to call and get a mobile response, and then have assistance up to 8 weeks to get their needs met and support and get connected to the systems that they need. So not necessarily fully behavioral health specific, but really partnering to have that be a children's front door instead of the emergency department or other areas. Looking at expanding the wraparound model beyond children and families in crisis and apply these models to populations so that, again, care can be integrated, sharing resources and information. And again, looking at some of the investments that were recently made for dual diagnosis of not only substance use disorder and mental health, but also intellectual and developmental disabilities and mental health. And there was, again, recent investment in this legislative session for us to move forward and do that. And then another activity is expanding the federally qualified health centers and tribal health centers to, again, do that more integrated model so that people can get what they need when they need it and not have to go through multiple doors to get it. Another strategy around incentivizing culturally responsive behavioral health treatments that are rooted in evidence-based and promising practices. And I gave a couple of examples of work that our unit is working on. I had notes that I want to make sure I don't get this wrong. One of the recent investments that we've been working on is the implementation of parent management training of Oregon, which was a evidence-based practice that was actually developed in Oregon and is used nationally and internationally, but had not been widespread implemented or utilized here in Oregon. And it's a model that's focused on strengthening, families at all levels for children, youth, couples, and has more than 50 years of research. And so we've been doing a train the trainer model as well as a demonstration project and expanding that model throughout Oregon. And similar with parent-child interaction therapy. And I know Lori Theodora, who oversees these investments and expansion, is, I believe, here today. And so if there's more questions about that, these models or the map of where they're located or the research behind them, feel free to, I'm putting Lori to work, but put stuff in the chat and I'm sure she can connect. The other area that our unit has been focusing on this is really creating low to no cost access to suicide prevention, intervention, and postvention trainings and programs. And I put a link there which gives an interactive PDF of the investments that we've really worked on through the 5-year plan, and making sure that folks have access to those trainings across the state. And then I know there's been more support on tribal best practices. We're going to hear from Yellowhawk today. And I know Medicaid has worked on freeing up the equine, a Medicaid code for equine therapy for the tribes. Another strategy, reduce systemic barriers to receiving behavioral health services, such as transportation, language, and assessment. And I loved what Tori was talking about around the rapid assessment. So again, when somebody's ready to engage in behavioral health, being able to access it right now. And that's a huge challenge and struggle in our state right now for a lot of reasons. But workforce being probably one of the number one reasons. But I think this is a huge strategy that we need to continue to focus on for not just substance use, but also for mental health. The expanded access to telehealth through the COVID crisis has been nationally celebrated by behavioral health and states. It's not for everybody, but it certainly has improved access and given some more creative strategies for states to support children, families, and adults through telehealth. And it's also been allowed to it's enabled us to utilize the workforce we do have in Oregon, further reaches into the corners of Oregon and to our rural and frontier partners. So I think thinking about it from a statewide perspective, it gives us a lot more flexibility and freedom. And I know there's a large advocacy at the national level to keep those telehealth billing codes through Medicaid available post the COVID state of emergency. We've been working on reducing barriers in our unit for children and young adults with intellectual and developmental disabilities. Typically in behavioral health, there's been a narrative around individuals not benefiting from behavioral health services or having certain number IQ cutoffs in order to access services. And so we have worked with our new intensive in-home behavioral health treatment as we've been rolling it out to name that cannot be a barrier to accessing this treatment, and working with our ESA partners on removing that as a barrier to accessing support for early psychosis. There's a pilot of rapid engagement model for behavioral health happening in Oregon. Again, similar to what Tori was talking about, is like when somebody needs it, lowering barriers in order to get folks in and engage in treatment, and have an opportunity to support any other barriers to treatment before diving into a full assessment and treatment plan. And then asking consumers about their experience in receiving care. I think this is something Oregon Health Authority, especially in behavioral health, we're looking at not just doing when we've created a paper and want feedback, but an ongoing cyclical feedback loop with consumers of behavioral health, so that we're getting constant feedback on how we're doing, and being able to be more flexible and nimble as we get that feedback to then be able to shift services and providing what people need when they need it.
I'm sorry, I didn't mean to wake you up.
Oh, please mute if you're able. There you go. So use of healthcare payment reform to ensure comprehensive behavioral health services are reimbursed. Talked a lot about the COVID response and some of the flexibilities that went into place there. We also recently got approved our substance use waiver for substance use disorder. And so there's a lot more around that implementation coming soon. Again, we can put the link to the website in the chat. And then the 1115 demonstration waiver, which is our CCO model, which is us saying to the federal government, we want to do Medicaid different in Oregon. And so our CCO model is that waiver. And that is up for renewal right now. So there is a lot of stakeholder and community engagement on different strategies that Oregon would like to explore for that next waiver. So I didn't put a link on the slide, but we can put a link in the chat around ways that you can get involved with that. And some of the examples of, ideas that the children's system has come up with is looking at, and for the adult system, is really looking at those transitions of care opportunities. So Medicaid, once you are, oh, thank you, Christy's she's like knocking out those links for you. So when you are in jail or incarcerated, or even if you're a youth that's in detention, your Medicaid actually stops. And so when you come out, when you're released, even if you weren't charged or anything else, when you're released, you have to sign back up for Medicaid. And that often can create a significant gap in care. So one of the ideas that's being discussed with this 1115 demonstration waiver is asking permission or looking with the federal government, is there a way that we can transition or overlap that care so that that Medicaid gap isn't the gap in care? And so that's a really exciting conversation that's happening. And so anyway, I won't go on too long because there's lots of information out there, but it's really exciting opportunities to think how creative, and Oregon's one of the most creative states I've ever worked in for Medicaid, and it just looks like it's going to get better and better. So encourage you to check that out. And then again, the telehealth, use of telehealth services and how Oregon's going to continue to use that and what's going to be paid for is a continued conversation. Continue to strengthen enforcement of the mental health parity and addictions law. My disclaimer is I am not an expert in this area, and so I don't want to speak too much about it and get myself in trouble. But I know there was a lot in this most recent legislative session around how to strengthen parity laws in Oregon and make sure that we're really looking at behavioral health, both substance use disorder and mental health, as it relates to a health service, a physical health service, and making sure that we're not creating more barriers than we in one area than we are in the other. And that also has to do with the amount of reimbursement that is happening for behavioral health, again, substance use disorder, mental health, and physical health. Increase resources and culturally responsive suicide prevention programs and for communities most at risk. There is a lot of work going on in this area that I, in a couple minutes, cannot do justice to. So I really do encourage you to check out the link, which is our annual report that we do for youth suicide prevention. The previous link that I had for the different training and information that we're funding for Oregon, and many of those trainings and a lot of the work that we're doing, not all of it is youth specific. So a lot of that also is lifespan. There's also been specific grants that have gone out to target different communities that are more at risk that I talked about a little bit earlier. There was legislation around schools and community mental health being able to share information so that communities can respond appropriately when there is at risk or when there has been someone who has died by suicide. There is a current development of an adult suicide intervention and prevention plan. And so if you are not already engaged in that, again, we can put a link in the chat of ways that you can get involved with the development of that. You can also go to the Alliance to Prevent Suicide's website, which again, I can put in there. Actually, it might be at the end of this presentation to get involved with that advisory group that works on the youth suicide intervention plan. And then also working with county epidemiologists to identify the commonalities of those who have completed suicide and really use that data to create relevant information. So I can explain that the group, we now have 5 OHA studies facilitating the creation of the adult suicide prevention plan. Oh, and popped her camera on. So she put her email in the chat. So if you are interested in connecting with that work, please do reach out because that work is really exciting. We're really excited about that work.
I believe Christy's back, Chelsea.
Excellent. Christy, do you want to take it from this slide?
Yeah, thank you so much, Chelsea. I am just having horrible bandwidth problems, but I'm glad I made it back. Thank you so much for that awesome overview. I just can't get over how much work is going on and how much work is to come with all the investments that we've seen out of the Oregon legislature. So would love to bring you back and keep us all informed about what happens with all of that investment. Before we move over to our presenters and guests, I just want to acknowledge that there are other behavioral health related strategies that live in other areas of the plan, right? Because behavioral health is so integrated and interconnected with every part of our lives. There are other strategies that came out of the behavioral health subcommittee that we have seeded in other areas of the plan. And so you can see here that there's a behavioral health strategy that lives within the healthy youth implementation area. As Chelsea noted, around the workforce barriers, there's a specific workforce development strategy related to behavioral health that lives in workforce development. Equity and justice, there's a strategy that lives there around building upon and creating BIPOC and tribal-led community solutions. So kind of a sister strategy to the strategy that Chelsea talked about, it's important to convene these groups at the state level as well as the community level. Within healthy communities, there's a strategy there specific to addressing loneliness and social connection among older adults. And finally, within housing and food, there's a strategy there specific to the use of housing first principles. And I'll just put a plug in that our next HTO in Action event will be focused on housing and food. And so if you are interested in learning more about that work, I encourage you to join us. All right, let's get into it. Chelsea, I think you are still driving, but I'm wondering if we can invite Winona and Fabian to come on. I'm going to turn it over to Winona Scott and Fabian Spencer from Yellowhawk Tribal Health Center to share a little bit about the equine therapy program that they are starting there. And Winona, I will turn it over to you.
Good morning, everyone. Sorry, I'm a little froggy. I'm dealing with allergies today. I'm gonna start our presentation here. My name's Winona Scott. I'm a chemical dependency counselor here at Yellowhawk. And my coworker, my colleague is also joining us. Fabian, would you like to introduce yourself?
Good morning, I'm Fabian Spencer. I'm the Native Connections Project Director here at Yellowhawk Tribal Health Center. And yeah, I'm coworker to Winona. So we've been collaborating a lot. She's done a lot of stuff and we've worked together to kind of get this program up and running. So it's been a journey. So I hope we enjoy the slideshow.
Okay, here we go. Can everyone see that okay? Okay. So our program that we're developing is called Kusami Nuked, and it means horse medicine in the Nez Perce and Cayuse language. We come from the Confederated Tribes of the Umatilla Indian Reservation, so the band is Cayuse, Umatilla, and Walla Walla tribes. Our agency is Yellowhawk Tribal Health Center, and this is the horse medicine program with SAMHSA Native Connections, which is where Fabian comes into play. Our mission statement is to provide a horse medicine program that incorporates Confederated Tribes of the Umatilla Indian Reservation horse culture with behavioral health services. The philosophy is preserving horse tradition and culture through healing and support. The vision is creating a sustainable behavioral health horse program for the people of the Confederated Tribes of the Umatilla Indian Reservation, a program that will develop into a multi-activity facility that promotes horse heritage. Here is a phonetic way of how to say it for those that want to learn. Kusami Taut Nuked. I always have trouble with that second T. Kusami Taut Nuked. Kusami Taut Nuked is a equine therapy service that is culturally specific to the community of the Confederated Tribes of the Umatilla Indian Reservation. So the picture is a group of us from Yellow Hawk who were specifically trained in being one with the spirit of the horse. The facilitator is on the far left, John Eagle Sr. with his daughter. And there's just a mix of us. My name again is Winona Scott. I'm a certified prevention specialist, ocular detoxification specialist, a traditional health worker, and a certified alcohol and drug counselor 1. I provide DUI services and also the culturally specific recovery services here at Yellow Hawk, which has an advisory board. And I have over 14 years of long-term recovery. Fabian, would you like to
Sure.
read this slide? Thank you.
As Winona was saying, that one picture that we had of the group of us, so this is the staff that completed the training in February of this year. But Winona, Julie Brandenburg, Sierra Klemps, Jay Sean Thompson, and Robbie Bill originally went to North Dakota in 2019 and they completed their Part 1 training. The rest of the staff, Mercedes Van Tassel, Cheryl Duran, and myself completed it in February. And this is with John Eagle Sr., and he has like years and years of experience. And we were fortunate enough to have his training incorporating into us being able to get our services going. So a lot of our staff, we're trying to, get as many as we can because we need CADCs, we need PRNs, we need THWs. So he's, actually here right now. I'm out in a training with him right now. Winona and I, Sierra and Jishan and Robbie were out there in our arena working with him. He also provides another Part 2 training that some of us did. We were very fortunate to go out to North Dakota once again to do a Part 2 training. He's out this week with us doing a mentoring program. So we're getting ready to start our live services. So he's coming out and just kind of working with us and preparing us to make sure that once we go out into the arena or, those sessions with our clients, that we're prepared. Like, what are we looking for? What are we looking for in the client, the horse, just basically preparing us. But this slide is just, like I said, our staff here at Yellow Hawk who are trained in the Part 1, becoming one with the spirit of the horse. The one photo on the bottom was in North Dakota, and then the one on the top right, that was here, our Fowler property. It's and on the reservation. So we kind of hold a lot of, we have a lot of our untouched horses. That's what we refer to them as. Other people might call them wild horses, but they are caught and they're here at this Fowler property where they actually auction them off. So yeah, we got a lot of horses that are out and about, and this is usually where they bring them. Let's see.
Should I go to the next slide?
Sure.
Okay.
And I think this one is yours.
Yeah.
Okay.
So our services are based on engaging Yellow Hawk patients, our clients, in these equine activities and tasks. So the learning objectives have been more of a strength-based versus deficit-based. And the example I always like to provide is, for a lot of our clients, it's hard for them just to walk through that front door and admit, that they need to be here, that they need to address certain issues. And sometimes we have to draw those things out in assessments and intakes, and it's breaking that stigma though. So those deficits can be whether they're court ordered to be here or whether they have some kind of consequence of their behavioral health or their addictions. So rather than just bringing those to the forefront, we also want to work on strength base. And so with being one of the spirit of the horse, it has taught me to pass this along to others. That we are implementing. I'll move on to the next slide. This is a short video that Elkhorn Media helped us with. It's been shared across our region. This one is the 1-minute video. I do have a 3-minute video that I can also send information about. So I'll go ahead and proceed with the video. Thank you. My name is Winona Scott.
Winona, I think we're having trouble hearing the audio.
Help.
There we go.
First medicine is healing. Maybe it's because I muted. Okay, let's try this again. My name is Winona Scott. I'm an enrolled member of the Confederated Tribes of the Umatilla Indian Reservation. I lost my family, my happiness, and my health. I've had thoughts of suicide. I've been drunk and high. I had to face my mental health. Horse medicine is healing. You have to experience it. So with the 3-minute video, I usually go into our connections are not just with the horses, but with each other, and learning how to help each other has made a huge difference. I'll go ahead and let Fabian take over this slide. Thank you.
So we have a lot of collaboration with a lot of entities that helped us get this program started. You know, we have equine therapy models, which, you know, come from a lot of our collaboration. We worked with like Dr. John Spence. He kind of helped us get our curriculum going. We have Native Connections, which I'm a part of. So that's a SAMHSA grant. So we were part of the 5-year grant. And before me, Ashley Harding was the Native Connections product director. And she kind of got, you know, her foot in the door to get us started on horse medicine. And then of course, OHA, we went through that to get our billing to be eligible to provide this culturally specific service to our people. And it's very unique. It's, you know, really awesome opportunity that we were able to do this. And, you know, we could help our mental health and our chemical dependency clients. And our service providers, of course, you know, all of the staff that are trained to be on our OHA billing guideline. We have CADC1 or CADC2 who can do the treatment plan. And then the PRMs and CRMs, of course, there to help and assist and guide the client, who can also be trained and provide services and be a facilitator. And then our mental health staff, who we have counselors who are also trained, and they work with the peer support specialist or the traditional health worker. So, you know, we have a lot of our team who've worked for a long time, for several years. And then it's not even just been us, you know, for decades, we've had our own tribal people who've really tried to establish this program. So we have a lot of our tribal elders who really, really worked hard and tried to get this off the ground. And now that we're getting going again, everybody's they're really excited. So I'm very, you know, proud to be a part of this program and help carry on those, visions that they had. And of course, again, the logistics and collaboration, it was just a lot of info, a lot of community events. They had a horse Gona here, a couple years ago, and a couple other events that we're also working with DCFS. DCFS, our Department of Children and Family Services, through the tribe. They also work with, families who are in foster care. They provide, an outdoor activity with horses. So they're trying to get their staff trained. So we're working with all these different entities, departments within our own tribe to kind of get this going. Of course, our tribal arena, which will come up as another department we worked with, is our public works department to get that going. So that's just kind of what this is information about. And then I guess the next slide.
Thank you.
Also, like I was saying, the curriculum, we worked with Dr. John Spence. He had a one-page document that he provided with us, and he told us, keep it simple, keep it basic, and that's what we did. We worked off the 4 stages that he had. So right now we just kind of said we want to provide tribal history, tribal horse culture. So that's our first lesson for some of our clients that will have come in. They'll learn about some of the families or some of the traditions and things like that. Of course, the huge one around here is Roundup. And then within the next lesson, we have horse safety. So we're going to work with the horse handlers, which is the next one, and they'll provide like the safety, body language, how to halter a horse, how to brush a horse, putting on the saddle, things like that. They'll talk about that first before actually going out into the field. And then lesson 3, again, is just going out into the arena. They might not just work with the horse at the beginning, and they might just go out and maybe muck stalls, or, just go out and like check out like how to use some of the tools. And then we'll gradually integrate them into working with the horse. But we're not going to be doing any riding. So there's no riding. It's all groundwork where we'll do some activities. They'll go, again, like I said, they might just go out and feed a horse for the day. Just kind of that quiet time, that interaction with the horse. So that is just what our curriculum is so far. Again, it's a active document that we can change as needed. So again, once our staff get out into the field and get into all this stuff, they'll be able to say this worked, this didn't work. So we're really doing a lot of test runs right now. And again, like I said, John Eagle is here to kind of help us, guide us, and like what's going to work specifically for us. And then horse handlers. We don't have any horses. We're not owning any horses at this time, sadly, but we are collaborating with our community. And that's a huge thing that everybody talks about, especially when we talk to Dr. John Spence and we talk to John Eagle Sr. He said community buy-in is a huge aspect to getting our program going. So for us, we're collaborating with our horse handlers, our people of, families that have horses. We want them to come in, provide their horses, be there with the horses while we work with the client, and just kind of having that relationship. And so that's what we're really trying to build right now, is get horse handlers. And then, like I said, our tribal arena, that was a huge project as well. And so that's what this picture is. In April, we had our grand opening of our tribal arena. So it was another, I think it hasn't been used for like a decade or so. So it was really run down, and we collaborated with Public Works and DCFS. And we got our arena up and running. So it's very beautiful out there, nice. The only thing is no shade. So we're out there tanning it up. But yeah, it's a nice arena. We're very proud to be out there. So you can see us all there bunched up, just taking a picture, and with the departments that we collaborated with. So that's out here on our reservation. It's a tribal property. We just, like I said, we worked with our board of trustees, say, hey, can we use this? And they're like, yep, they're in full support. They really want us to get this horse medicine program up and running. Next slide. Any Q&A?
Winona and Fabian, thank you so much for sharing this work. Yeah, it's just so beautiful, and would love to bring you back at some point, if you're willing to share some of the stories of healing and recovery that come out of this program. I'm sure we'd all love to hear how it's going. I'm going to hold for questions. Unfortunately, just for the interest of time, we've got a couple speakers I want to make sure we have time for. Of course, folks are welcome to put in questions in the chat. I know there's lots of accolades and love being sent your way for sharing this. I'm gonna also, we're gonna show a video from Holistic Healing Behavioral Healthcare. We will share that video with the materials that we send out. Holistic Healing was gonna join us today. They provide culturally responsive behavioral health services to primarily the Black community in Portland, and just doing really great work. So we will share information about them. But I will turn it over now to Amber Ziering with the Oregon Pediatric Society. There she is. Hi, Amber. Floor is yours.
So I'm going to share my screen. Does that show up correctly for everyone? Yes. I don't think anybody nodding. Okay. I'm Amber Ziering, and I'm the project manager for Oregon Pediatric Society. We are the Oregon chapter of the American Academy of Pediatrics, which is a member organization for pediatricians. We as an organization provide a strong statewide voice for the health and well-being of all children while supporting those that care for them. OPS provides continuing education with an emphasis on behavioral health, quality improvement projects, and peer networking for child health providers, as well as working with community partners on health equity, healthcare transformation, and child-focused policies.
Hey, Amber, just so you know, the view you're showing is sort of showing the next slide in your notes.
Oh.
So I don't know if you want to switch to the other.
Yeah.
I know sometimes when you share your screen, it's like it gives you like 6 choices and it's very confusing.
No, I appreciate that information. Let's see. I will keep talking while I work on sharing screen appropriately.
Amber, I can also try and bring it up if you want to.
Let's see. Is that correct for you?
Oh, there you go. You did it.
All right. All right. Just a little bit of technology glitch. It's not 2021 if we don't do that, right? Okay, so since 2008, we have trained over 7,000 child health providers across the state. We provide training related to substance use via this SBIRT tool, depression, ACEs and trauma-informed care, suicide prevention, developmental health, perinatal depression, and we added anxiety in this last year as well. Rather than simply providing a single one-off training, OPS training includes support for practice change, for improving the way that you address that need within your clinic or within your healthcare setting, and learning collaboratives to share the knowledge across providers and across settings. We also host panels of local resources such as early intervention, home visiting, childcare resource and referral, and additional training to facilitate relationship building within the communities that we train in. We are definitely excited to return to facilitating this resource connection now that we can gather in person again. That will be exciting to have back. During the pandemic, we also added supports to promote provider and patient resiliency, addressing the mental health impacts of the pandemic, as well as transitioning most of our training online. This included how to conduct a suicide screening virtually, especially when it felt unsafe, perhaps because of COVID, to refer patients to the ER. Just building resiliency and prolonged adversity for providers, and virtual substance use screening. All of these things had always been done in person before, and so we facilitated the learning towards that. Our virtual learning also included an anxiety echo, which is a model of teaching that's meant to share specialty skills, often limited to specific regions of the state, such as urban centers, to providers throughout the state who before would be limited in their capacity to leave their communities to receive high quality training. The ECHO's ongoing learning collaborative has focused on supporting anxiety in primary care in order to bridge the gap between the time that the need is identified and the wait that referrals can often take to get to mental health services. And a new aspect for OPS that came in the last year or so has been the intentional mix of participants. Our previous model, we would train a clinic together, but with an ECHO model, this allows us to have many clinics together as well as invite behavioral health providers into our space. So the dialogues that were created about anxiety and how you approach it and how you treat it were much richer because we had such a variety of professions and skills approaching the problem together. And one of our participants has stated that one of the silver linings for her as a rural provider of the COVID pandemic has been the quality of training that has gone virtual has allowed her to expand her practice in a way that she couldn't before, just due to the limits of geography. And we are very happy to have been part of that solution. In addition to that, we worked on the project of addressing social health and early childhood wellness. We call it ASHU, which focused on the social determinants of health for children age of 5 and under, as well as their families, helping members of the project recognize that a child is part of a system and that you can't just treat the child alone if you're going to help to address the long-term needs of the child and their family. The project has worked to increase screening and referral, closing the referral loop so that when a provider makes a referral, they know that the family has accessed the service that they needed. And if not, finding out why and finding a way to address that need if there was some issue within the referral itself. And then also working to include family voice in the practice change to make sure that families and youth are represented in the work that we do because the work is to serve them. So right now with ASHU, we're currently focusing on the sustainability of practice change and disseminating the learning to medical practices that weren't able to participate in the original project. And then finally, this year has brought about youth suicide assessment in virtual environments, which was created in collaboration with Oregon Health Authority and the Association of Oregon County Mental Health Providers, to help schools and other community-based mental health providers address suicide prevention and intervention in a virtual context. How is it that you reach out to a youth when they're not sitting there in the office with you? This virtual training was formed in the shadow of a pandemic and racial reckoning in our communities. And due to this, we made sure that we were explicitly addressing equity and intersectionality while focusing solely on youth. Other suicide prevention and intervention trainings looks at the entire population, whereas we focused our interventions with those from the age of 10 to 18. Youth Safe promotes relational interventions for the youth experiencing thoughts of suicide. And so far, over 550 providers have been trained since November of 2020. And then our next phase of Youth Safe will focus on helping mental health professionals use the skills virtually that we taught them as well as in person. We think that the virtual environment isn't going to change entirely, isn't going to go away entirely, even as we regather as a community. We understand that the virtual context served many people quite well, and so we want to equip youth serving mental health providers to know that they can use skills virtually and in person and have competence in both settings. That is all that I have. I would be happy to have any questions, but I know that we're waiting until the end for that.
Yeah, thank you so much, Amber. Super important work. And yeah, we are running short on time, so please put your questions in the chat. I'm sure Amber And Winona and Fabian as well would love to connect with you offline with any of your questions. But we have one more presenter, so I'm going to turn it over to Robin Pfeiffer from Citizens for Safe, oh boy.
Schools.
Thank you. Take it away,
Okay.
Robin.
Okay, I just shared my screen. Can people see it? All right.
Yep, you're good.
Okay, perfect. So hello, thank you for having us today. My name is Robin Pfeiffer, and I'm the Executive Director of Citizens for Safe Schools. We are a youth mentoring organization here in Klamath Falls, Oregon. And I am here today with my partner in crime, my program director, Stephanie Sullivan. She's waving in the chat. And so just first, a land acknowledgement. We live on the traditional lands of the Klamath, Modoc, and Yahuskin tribes, who are three separate tribes, three separate people with individual cultures and customs. Also, as many of you may know, the bootleg fire here in Klamath County is the largest wildfire in the nation right now, and it is burning in the ancestral homelands of the Klamath and the Yahuskin tribes. So I just want to make an acknowledgement about how awful that is, and devastating and heartbreaking for those that are losing their homes and also their traditional sacred sites. I know we don't have a whole lot of time, so I'm going to try to get through this in just a few minutes so we can take some questions at the end. So like I said, my name's Robin, and I am the Executive Director of Citizens for Safe Schools. We are a youth mentoring organization. We've been operating as a grassroots nonprofit for 22 years now in Klamath Falls. Some of you may recognize me. I used to work at Klamath County Public Health, so I know a few of you from my public health days, so thanks for having me. But today, we're really going to focus on one of our newer programs, our Citizens Pride Circle, which is our LGBTQ specific mentoring program. And this program was started with seed funding from the Oregon Health Authority and the Oregon Alliance to Prevent Suicide through their LGBTQ mini grant program. So OHA was integral in starting this program here locally. So just wanted to give you a little bit of information about what we're doing here in rural Southern Oregon to serve LGBTQ youth. Just a little bit about why we do youth mentoring. The years between childhood and adulthood represent a critical period of transition in children's lives, mentally, emotionally, and socially. While adolescence is a time of tremendous growth and potential, there can be a lot of added risk factors that can make navigating these challenges difficult. But research for many decades has been very clear that mentoring, a single, caring, consistent, positive role model, is a very powerful protective factor and connects youth with the support to walk alongside them through their struggles and providing hope and opportunity for the future. So for a long time at Citizens, we have been operating our Kids in the Middle program, which is our one-to-one mentoring program. This is very similar to Big Brother, Big Sister, if you are familiar with the national program. However, Stephanie and I, for several years, have been talking about starting an LGBTQ specific youth program and specifically a mentoring program here in Klamath County. There is, in rural communities like ours, there's often a perception that there isn't a queer community or that we're siloed and we don't know about each other. And that's, this actually has been for our queer community locally, a lot of things for adults. Our UU Social Justice Committee has, a big queer community. Both Oregon Tech and Klamath Community College were operating groups, but there wasn't really much for youth to connect with each other and then also connect with adults, with adult queer folks to learn their stories and to develop kind of a mentoring relationship. That kind of brings us into our why we started what we call our Pride Circle, our LGBTQ specific and Two-Spirit specific mentoring program. Here locally in Klamath, we are a pretty conservative community. A lot of kids live in non-affirming households and also experience bias, stigma, and victimization in their social lives, specifically at school. Here locally, we did have a few youth suicides in the last couple of years that were queer kids who took their lives because of bullying related to their queer identities. So locally, we had these terrible tragedies with youth that were known and loved by us in the community. And then also in 2020, the Oregon Safe Schools and Community Coalition published a report. It was called, the 2020 report said, State of Safe Schools Report, Unsafe, Unseen, Unacknowledged, Addressing Hostile Educational Conditions for LGBTQ Youth in Oregon. And in this report, it indicates the LGBTQ youth in Oregon, so LGBT Oregon students are at a significantly high risk for bullying, school-based violence, sexual assault, absences from school, and suicidal ideation. So we knew this was a huge problem. And so when the LGBTQ mini grant came out, we knew it was the perfect opportunity to start some prevention and intervention programming here locally for our underserved community. So we applied, we were awarded, and so we started developing our Pride Circle. And Stephanie really, my program director, really did a lot of that program development. We adapted a curriculum. If you want more stats, I have them here, but we adapted a curriculum from the One Circle Foundation to be specific to LGBTQ youth populations, and specifically LGBTQ youth populations in rural areas. And so we started our Citizens Pride Circle, and it's a circle mentoring program, meaning that we have a community of mentors and a community of mentees. We meet weekly, either via Zoom, or now that COVID is a little bit better, we do have some small group in-person activities that we have been implementing over the last month. But we meet every Tuesday, and we follow, that adapted curriculum that Stephanie's created. So here's some of our participants in our Pride Circle. As you can see, the biggest thing about Pride Circle is creating a safe and affirming community for LGBTQ kids and adults. So what is Pride Circle? It's a youth-led, professionally facilitated mentoring circle, providing youth with a network of allies, centering emotional, social, and informational supports to build resiliency against suicide risk. So through our Pride Circle, we amplify protective factors and create space for LGBTQ+ and Two-Spirit youth to question, explore, accept, celebrate, and share their identities within a safe and affirming community of peers and mentors. And so, how much time do I have? I think I have like 3 minutes, so I'll go through it. It's Pride Circle really encompasses culturally relevant, responsive learning, social and emotional resiliency, and skill building. We partner with our local mental health authority, and once a month a skill builder comes in, a mental health therapist, and facilitates one of our Pride Circles a month. Other things that we do, we adapted some sources of strength lessons to the curriculum. Sometimes we have local queer guest speakers who come in who maybe have grown up here or live here now and talk about their life, the things that and their successes, right? Focusing on that strength building, so our youth can see successful and happy queer adults in the community, and learn from them and connect with them. So that's the connection to community role models there. And then suicide prevention skills and learning, like I talked about, we do some sources of strength. I'm a QPR trainer. We're trying to implement kind of all the big 6 suicide prevention trainings into our curriculum. But the most important thing of all about our Pride Circle is it's a safe, affirming network of supportive relationships and community belonging. Here you can see mentored LGBTQ youth are less likely to experience depression, anxiety, and identity-related stress. Mentoring an LGBTQ youth reduces suicide risk by up to 40%. That's statistics from the Trevor Project. And here's a quote from one of our 13-year-old mentees. Before Pride Circle, I was different from other kids. And now I have lots of friends and mentors who are just like me. I know I'm not alone anymore. So from one of our mentees. And we have a lot of artwork that we've had throughout. We do a lot of, in our Pride Circles, shared whiteboard activities, you know, drawing, you know, affirmations and whatnot. But I think really, you know, Stephanie, you can speak to this more as well. We've seen a lot of mentees really come out of their shell during Pride Circle and develop relationships with mentors who have similar lived experience as them, whether transitioning or the home life that they've grown up with, etc. And really latching on to those community mentors through Pride Circle and building their resiliency that way has been, you know, a huge success for us. Like I said, we started this program with seed funding through OHA, and we have secured additional funding through the Collins Foundation to continue this program for years to come. So we're super excited that, you know, we're an LGBTQ youth program in rural Oregon. So Steph, is there anything that I missed that you want to add in?
I think you know, pretty much covered all of the basics. You know, this, like Robin mentioned, was kind of on our radar and a hope for the future for a long time. And, you know, as a rural community who is very conservative during the COVID-19 pandemic, at least the beginning of it, when, you know, people were kind of stuck in their homes, our LGBTQ kids were especially at risk, being further disconnected from their supports, from their, you know, affirming peers, and a lot of them confined with like non-affirming families in close quarters. So just being able to create this affirming space and provide access to peers that are like them has really just given us a chance to do some community building, build up that affirmation for these great kids, and just most importantly, exposing them to others who are like them, and you know, role models and supporters, and just teaching the power of visibility and representation. So yeah, the community building has been really life-saving for our kids. So that's about it.
It's also been super impactful for our adult mentors who, you know, we have some queer elders in the program who are more connected to the queer community locally because of Pride Circle. So yeah.
And also I think, you know, there have been a lot of unexpected kind of side projects that have kind of happened because of our gathering of these youth and mentors. We have one of our youngest participants, I think Mark Hill's maybe like 9, created an anti-bullying presentation specifically, you know, about LGBTQ kids. One of our youth leaders created a Trans Visibility Day presentation. And then our group was asked to present to our local mental health authority on gender diversity and mental health. And they really just kind of created something so impactful and just amazing resources, and collecting the experiences of rural queers to kind of shed some light on how queers experience mental health systems, and then presented to, you know, all 200 staff of our mental health authority. And since that presentation, we've been asked to do one by the DA. And so, you know, we really have, one of our goals was to empower these kids with, you know, self-advocacy skills. And we're seeing not only are they advocating for themselves, but they're advocating for their community within our larger community as well. So that's been one of the really amazing takeaways out of just many that we are kind of seeing happen as we move forward with this group. So we're really excited for in-person stuff now too, and what that's going to look like for us. So yeah, thank you guys for letting us share about our project with you.
Yeah.
Robin and Stephanie, thank you so much. Lots of love coming to you in the chat. People just so impressed with how you brought this together at such an important time, particularly in Klamath. Really great example of how this work can happen. And I think you've hopefully spurred some ideas that people can replicate in their own community. I know we're out of time and I apologize for that. I kind of knew this was going to happen. So we ran out of time for questions. I'm happy to stay on, and if folks want to stay on and keep chatting, please do so. Chelsea, are you still there?
Yes, I'm still here.
Yeah, I'm wondering, I just had a few closeouts. If you could pull back the slides up, and looks like we still have 80 people holding on. So please tee up your questions for folks. And if anyone has had to step away, I'll make sure you get those. But just wanted to provide a few announcements and final thoughts here.
Sorry.
Oh, it's okay.
Yeah.
Yeah, we will send out recording and slides and materials. And if it's okay with the presenters, contact information for you all as well. So if people want to get in touch, they know how to do that. We definitely welcome you to join us for another event in this series. We've got Housing and Food coming up on September 22nd and Healthy Families on November 15th. We will send out a link to a website where you can get registered for those events and stay in the loop. If you have any questions, or if you want to continue the conversation, we have a base camp that is set up for Healthier Together Oregon. I don't know if you are familiar with base camp, but it's an online platform, and would love to bring you into that. If you are interested in getting into that base camp and just being able to connect with other people who are doing this work, please email us. Chelsea, it's on the next slide, if you don't mind. publichealthpolicy@state.org.us. There you go. Just send us an email, let us know, hey, I want to be in the base camp for behavioral health, and we will get you an invite. And then finally, your feedback is really important to us as we continue to roll these events out. So there is a quick evaluation. If you would be so kind to let us know your thoughts, that would be great. And I'm going to stop talking. Anyone have any questions or reactions, thoughts? The floor is open for folks to unmute or chat away. Looks like we got a few folks, at least Robin and Amber and Stephanie are still with us. Tori, I don't know if you had I'm just scrolling through the chat here to look at other questions. And I got booted out a couple times, so you might have responded to this, but I know there was a question earlier about the connection of the Measure 110 group.
Yeah, I was able to answer
Okay.
Ms. Diane's question, and we're going to connect offline in the
Oh,
meeting.
great. Okay. I'm wondering, Heather or Liz, were there any other questions that came up in the chat that we could bring forward?
This is Liz. There was only one other one that I saw, and it was quite earlier, but it said, has anyone talked about how some harm reduction strategies are confusing and working against other recovery outcomes?
Tori or Chelsea, do you want to take that one on?
This is, oh, go ahead, Tori.
Really quickly, one example is we do understand that some people may be triggered by others who are within the harm reduction area of the spectrum. And so I know as it relates to housing, we wanting to be very specific about which populations for which housing components, again, so that we can set people up for success. And so we do consider those things when creating resources.
And this is Chelsea. I would just add that in the children's community, I think we do hear confusion about that term and the definition of it, and that multiple people have different definitions as it relates to children and treatment. And so like a spectrum, everything from teaching children how to use drugs safely versus creating a safe place for children to access treatment while potentially still using all the way to recovery. So I think I would agree from the children's behavioral health system, one of our goals to work with AdPC and others is to help define that as it relates to children so that we can all come to some common language so that when we are using that term harm reduction, we know what we're referencing. A good question.
Thank you. Another question here. I'm curious if there is or will be funding available for community-based mobile crisis response programs.
Good question. I can answer that. So we did get investment this legislative session for the children's system to develop mobile response and stabilization. It is at the beginning phases and so of development, because again, we want to restructure that front door, not just create another new service across the state of Oregon. But there was funding for partial, so 6.5 million of general fund for a partial biennium and beginning of investment. And this will be tied to the work around 988 development in Oregon as well. And so there'll be lots of work groups and opportunities to engage both in the larger adult system, but also the children's system development of 988. So we're starting at the beginning stages of, this was a policy option idea and there's best practices nationally. We have a national consultant we're working with to develop that funding and how that will be implemented in Oregon. So lots more to come. It's very exciting.
Tori, question for you. I'm a little confused by what I'm perceiving as being a separation of alcohol and drug treatment and mental health. And it looks like Tammy Stump is wanting to connect with you offline. So I'll let you all.
Awesome. That's I would love to help with the confusion. Let's connect. I'll send you my email address. Well, I'll send it to everyone. It'll be in the chat.
Yeah, and I would just add a little bit to that is that there was, and I didn't, I think, go into it in detail, obviously, because it was such a big overview, but there was great investment this legislative session around treatment for co-occurring. And actually more of a movement from the legislature and Medicaid to work to combine and really reimburse providers that are already doing that work together. So, and that is also, that's not just substance use disorder and mental health, it's also intellectual developmental disability and mental health. So I would say there's a policy, if I could talk, a policy shift happening in Oregon around combining and also looking how to put that in the infrastructure and not just another reimbursement rate. So really identifying that these are whole people that need interventions that are addressing the whole person. And while there may be expertise in our different fields, we need to start bringing them and working together so that the person is getting their needs met. And again, not looking at that multiple door intervention. I think the other thing I'll just quickly add, because it was quiet for a second, is that I think when Oregon decided to, this is my own personal opinion, not Oregon health authorities, but I think when we combined substance use disorder and mental health into the term behavioral health, I think it was with the intention to really bring along and elevate substance use disorder work, but oftentimes it's being used in congruent with mental health. And so sometimes those conversations, we're talking about behavioral health, but then all we mention is mental health. So I do think in narrative, you may see more of a separation from the Oregon Health Authority and others to, again, continue to elevate that work. But it's not to try to separate. It's more of like, wait, you might have forgotten us around substance use work and the work, co-occurring work for intellectual and developmental disabilities. So I'm not speaking for the whole authority on that, but I know in our world, we're starting to separate the language a little bit more to make sure that group and that work is not being overshadowed by mental health.
Yeah, I agree 100%, Chelsea. We've updated our term, but we still don't always practice what the term really means or what it really encompasses.
Yeah. And language is important.
Mm-hmm. Yeah, Chelsea and Tori, this is Christy. Do you ever hear any whispers, or I guess anyone, about even shifting away from the term behavioral health to something more about like brain health, to kind of catch up with our advancements and understanding around, neurology being the driver of so much of this stuff?
That's a good question. I myself haven't heard anyone use that term, but I do agree with what Chelsea's saying. Like, we have updated our language, but very similarly to harm reduction, we don't all have a universal definition. And so we're still working on that piece of the name change.
Mm-hmm.
Yeah, I would add that I haven't heard that particular term either in the children's world, but I have started to hear, talk of using the term wellness or whole health or whole person or whole child. I think that language is happening a lot more as we look at the, health complexities of how physical health plays into mental and substance use. And so I am hearing that conversation, but it'll definitely be an evolution of terms. I think the hope is that we don't, again, if we get too broad, what I've seen happen is that we start forgetting population. So we just got to be careful with our language, but also make it as inclusive as possible so that we're not continuing to isolate certain populations.
All right, last call for questions. I want to thank presenters for hanging out. We had such great interest, people really staying on. So I think this really filled a need for people. And thanks so much for all your praise and appreciation in the chat. Thanks so much for tuning in, everybody, and for doing this hard and important work. All right. Have a good afternoon, everybody. Take care.
Thanks, everyone.